Go ahead. Thank you, Dad, for doing this.
Hi, this is Mark Rothstein with an update on COVID-19. And let me start out with my usual disclaimers. I am not a physician. I am not providing medical advice or information, so you should consult your own physician for medical advice. I'm also not a virologist or an epidemiologist or many other kinds of scientists. My background is in law, and my expertise is in public health law, policy, and ethics. I began working on coronavirus policy in 2003 when CDC asked me to write a report on US public health policy for SARS, which I did. And I've been interested in coronavirus issues ever since. I served for 8 years as associate editor for public health ethics and law of the American Journal of Public Health, and I've published several articles on COVID-19. Finally, as I'm sure all of you know, the science keeps changing, and my goal is simply to provide information that is accurate and up to date as of today, and today's date is August 4th, 2021. I'm going to talk about 3 main categories of questions that were sent to me by Julia. First, what are the risks associated with the Delta variant? Second, what should be our policy on vaccination and masking? And then third, the same question I was asked January 7th, and that was, how long will this pandemic last? So first, about the Delta variant. The Delta variant arose in India in February or March of this year. And because it was so highly transmissible, it quickly replaced the Alpha variant as the dominant strain. And although the numbers are not very accurate, the Delta variant has been estimated to have caused at least 1 million deaths just in India. In the few months since it first appeared in the US, the Delta variant has quickly become the most dominant strain here, and it's now responsible for 93% of COVID cases. It's more transmissible because people who are infected with the Delta variant, even those who show no symptoms or only mild ones, have a higher concentration of virus in their noses and other parts of their body, and estimated 1,000 times higher than with earlier strains. Viral concentration is extremely important in transmission. Even unvaccinated people will not become infected if they are exposed to low doses of the virus. That's why CDC has advised that if possible, we should stay outside and have good ventilation when we're in enclosed spaces. The fresh air dilutes the virus to levels where it's not transmissible. And those measures that we started last year, unfortunately, are even more important now. Scientifically, transmissibility is based on 3 variables. First, the duration of infectivity after the individual is infected. Second, the likelihood of transmission of infection per contact between a susceptible person and an infectious individual. And third is the contact rate. You might recall that in the earlier talk, I mentioned that experts predicted that herd immunity or community immunity would be reached when 70 to 85% of people are vaccinated. And just this past week, the US finally reached 70%, but the earlier estimate was made before the Delta variant. And now, in light of the 3 variables I just mentioned, we need something approaching or exceeding the high end of this prior estimate. The Delta variant has caused more so-called breakthrough infections of vaccinated people, but there is some good news to report. Even though there are more infections of vaccinated people, the percentage is still quite low. There have been 6,600 breakthrough infections out of 163 million fully vaccinated people. Even better, most of those infected have no symptoms or only mild symptoms. The mRNA vaccines of Pfizer and Moderna are effective in preventing infection and extremely effective in preventing serious illness or death. According to the latest figures from the CDC, 97% of hospitalizations and 99.5% of fatalities are of unvaccinated people. Truly, this is an outbreak of the unvaccinated. The Delta variant also infects younger unvaccinated people at a higher rate than before and causes more severe symptoms than before. And people who have recovered from a bout with COVID do not seem to have immunity to the Delta variant. Another area of great concern is that vaccinated people can become infected and infect other vaccinated people, as well as people who cannot be vaccinated, such as children or adults with rare vaccine allergies. That is a risk, no doubt about it, but the likelihood of infection and then transmission is very low. So we should be prudent, but not paralyzed by fear. The second main group of questions that I want to address deal with vaccination and masking. And here I want to repeat the specific questions I was asked to comment about. So first question, should I be concerned about the long-term side effects of the vaccine? The obvious answer is that it's impossible to predict whether there will be long-term effects because the vaccines have been used for less than a year. But there is good reason to expect that there will be very few new side effects. The mRNA vaccines, that is Pfizer and Moderna, have extremely low levels of side effects, and they have been given to hundreds of millions of people already. Also, side effects from all vaccines seem to manifest shortly after vaccination or within a matter of days or certainly weeks. If you want to look at this question more fatalistically, I would say if you don't get vaccinated because you're afraid of possible side effects 10 years from now, there's a much higher chance that you'll be very sick or dead within 10 years. Next question. When do you think the vaccines will get full approval from the FDA? Now, this is very important because there are some people who think that emergency use authorization means that the vaccine is experimental. And as I explained in my January 7th video, this is clearly not the case. But full approval, I think, will make it much easier for employers, schools, businesses, and the government to make vaccination mandatory. In answering a related question, I think that vaccination should be mandatory for teachers, staff, and children over 12 to attend school. Pfizer filed an application with the FDA for full approval on May 7th of this year. Moderna filed in June. Standard approval usually takes 12 months. Expedited approval usually takes 8 months. Dr. Peter Marks, who is the director of the FDA Center for Biologics Evaluation and Research, which regulates vaccines, recently said that the FDA is moving as quickly as possible, but they can't shortcut the process, which includes inspecting all facilities that make the vaccine. And Pfizer produces the vaccine at several facilities outside the United States. The FDA also must follow up on all adverse events reports. And with 100 or so million people taking the Pfizer vaccine, that's a significant number that they need to check up on. It was reported today, in fact, in the New York Times, that the FDA is working to grant full approval to at least the Pfizer vaccine by Labor Day. That would certainly help. Another recent study reported today as well said that 3 of 10 vaccine hesitant people would become vaccinated if there was full approval. I don't know whether that's accurate or not, but it certainly wouldn't hurt. Next question. When will the vaccine be approved for children under 12? Again, it's important not to cut corners or be perceived as cutting corners, because I think, unfortunately, many people are looking for an excuse not to have their children vaccinated. I think approval for children also will occur within a month. I hoped it would be before children have to return to school, but that's obviously not going to happen. Next question. What about booster shots for people who are immunocompromised? There may be as many as 10 million people in the US who are immunocompromised, and it is a very heterogeneous group, including people who have autoimmune diseases, transplant recipients, chemotherapy patients, HIV/AIDS patients, and others. Some immunocompromised people do not respond to the vaccine by producing adequate levels of COVID antibodies. And some immunocompromised people may lose their immunity more quickly. A booster is a way to increase their antibody levels. Boosters have been used in France, Germany, Israel, and a few other countries for vulnerable individuals, but there's no compelling evidence that at this time boosters should be given more widely. The CDC and FDA are working on guidelines for giving booster shots to immunocompromised individuals. And I hope the guidelines will be issued within the next month, but they've got a full plate for things that they have to get out in the next month. Even without CDC guidance, immunocompromised individuals might want to ask their treating physicians whether it would be a good idea to have an IgG COVID test to measure whether they are producing antibodies after their vaccination. This test is only one measure of the body's complex immune system to fight off an infection, but I think it's a good starting point. Here's another bit of good news for immunocompromised individuals that was announced Monday, August 2nd. The FDA approved for the first time an injectable coronavirus antibody treatment after someone has been exposed to the virus. According to the FDA authorization to receive this preventive treatment, individuals must be unvaccinated or immunocompromised, at high risk of COVID, and must have been in close contact with someone who has tested positive. The treatment is a monoclonal antibody treatment using two types of monoclonal antibodies. The first injection must be administered within 96 hours of exposure, and the cost of this treatment is covered by the federal government. Next question. Should vaccinated people start wearing masks again? Unfortunately, I think the answer is yes, certainly in areas with a high rate of infection, indoors, and where social distancing is not possible. Personally, I have resumed wearing a mask to my office at the medical school because I ride on a public elevator. I've also noticed an increased number of my colleagues wearing masks. The recent CDC masking guidelines are designed to prevent vaccinated people from becoming infected and infecting unvaccinated people, including children under 12 who can't be vaccinated at the moment. Masking will not protect most unvaccinated adults simply because people who decline vaccination also tend not to wear masks or to wear them, or they wear them improperly. Next question. When will employers adopt policy, when adopt policy about vaccination, testing?
Good.
Next question. When employers adopt policies about vaccination, testing, masking, etc., are they legally obligated to enforce them? Most employers are not required to adopt these policies, which means they can change the policy whenever they want or not enforce them. However, it would be illegal for an employer to discriminate in enforcement, such as selective enforcement or disciplining non-compliant employees more harshly based on race, color, religion, sex, national origin, age, disability, union membership, and in some states, even more prescribed criteria. I think vaccination is easier to enforce than masking because you basically only have to do it once. And you don't have to constantly monitor people to make sure that their mask covers their nose and mouth and so forth. For large companies, the fear of adverse publicity also might encourage them to enforce the rules they establish. And now the final question, how long will the pandemic last? This was the same question I answered on January 7th in my video. And here's what I said then, quote, I wish I knew. Dr. Fauci said that we could see a return to some level of normalcy at the beginning of the fall. I hope he's right, but I wouldn't bet on it. End quote. Now it seems we were both half right. We were able to return to a level of normalcy in the summer, but the Delta variant and vaccine resistance has put us back where we were in the winter, with spiking levels of infection, hospitalization, and death. According to one recent estimate, at current vaccination levels, another 100,000 to 200,000 people are likely to die by the end of the year, and almost all these deaths are preventable if the nearly 100 million unvaccinated adults in the US would be vaccinated. In the long run, many experts think COVID will become an endemic seasonal illness, similar to more common and less deadly coronaviruses. It will be like the common cold for people who are vaccinated. There is another more apocalyptic possibility. When an unstable, lethal virus is free to circulate and reproduce in millions of people, there is a significant chance that it will mutate into more transmissible and deadly forms. That's exactly what happened with the Delta variant. There's no scientific reason why the Delta variant couldn't mutate into an even deadlier strain, perhaps one that is impervious to our vaccines. In fact, there already is what's called a Delta plus variant that is more transmissible and more damaging to lungs. The best way to prevent this nightmare scenario of ever more deadly variants is to have overwhelming numbers of people vaccinated, which would greatly reduce the number of viral reproductions. And that requires not only vaccination in the US, but vaccinating people all over the world. Finally, some good news to report. It seems that the rate of vaccination has increased significantly in the past week to about 446,000 people getting their first shot each day, with the greatest increases in areas where there was a low vaccination rate and a high infection rate. So maybe vaccine hesitant people will finally decide to do the right thing, and the vaccination rate will increase to over 1 to 2 million a day as it was in the spring. So thank you for your questions and for watching to the end of this video. I wish you all good health and happiness.
Would you mind just quickly explaining why HIPAA and the Nuremberg codes don't apply? I see more stuff about why people can't ask you about your vaccination status because of HIPAA than anything else, and it's foolish.
Okay, so I have another couple of questions that just came in. And the first one is about whether HIPAA, the Health Insurance Portability and Accountability Act privacy rule, applies when people are asked whether they have been vaccinated. And the answer is no. HIPAA is one of the most misunderstood federal laws and regulations that I've ever seen. HIPAA only applies to 4 classes of so-called covered entities: healthcare providers, healthcare plans, healthcare clearinghouses that package bills and put them in common formats, and their business associates. It doesn't apply to schools. It doesn't apply to employers. It doesn't apply to insurers who are other than health insurers and a whole range of other people. So the HIPAA privacy rule would not apply to an individual who is asked whether they have been vaccinated. They can answer it if they want. They can decline if they want, but HIPAA is no part of that. Okay, the second question was, do the Nuremberg codes apply to vaccination? And the answer is, first of all, the Nuremberg codes are not mandatory anywhere. It's an excellent starting point for research ethics. The research ethics regulations in the United States are what's known as the common rule, so-called because they apply to all the federal agencies that conduct or sponsor research. But the more important point is that vaccination, even under an emergency use authorization, is not research. It was used in research studies in the fall of 2020 to justify and in support of the granting of an emergency use authorization. The emergency use authorization was a ratification, if you will, that the research was successful. And that's why it was approved. And that's why I expect it to be fully approved within a matter of weeks. But in each of those questions, I think it reflects more misunderstanding about vaccination and about COVID-19, and I think it's important to clarify them.
Thank you so much, Dad. I appreciate you taking time to do this again for my friends. And I know they very much appreciate it. Everyone was very excited that you would be doing an update.
Okay, do you think I got all their questions?